I am Timothy Donahue. I am a professor of surgery and chief of the Division of Surgical Oncology. I'm vice chair for surgical cancer care at the David Geffen School of Medicine and UCLA Health. The question is, should patients with metastatic pancreatic cancer ever undergo surgery? This is another good question that doesn't really have an answer or a well-defined answer or clear answer. The way that we separate things is what we call it depends on so it really depends on the patient's. And overall, in general, patients with metastatic pancreatic cancer at this point are not usually recommended to undergo surgery. This is a very aggressive tumor, very aggressive biology, and for the most part, experience has told us that when patients have metastatic disease, that there is almost certainly a subclinical, undetectable additional metastatic foci that will eventually grow and turn into a recurrent or even persistent a cancer. I'd say that the thought on that is changing a little bit now, in that we're looking for patients who have what we consider to be oligometastatic disease. So, one or two very small metastatic foci at presentation are thought to potentially be different than those who present with much more overwhelming metastatic tumor burden. And those patients with very small metastases may be considered for surgical resection, as long as it is thought that the tumors at the time of surgery or all the detectable disease can be removed and have the margins be negative. Never, ever, ever should these patients undergo surgery without being treated with systemic therapy first. Ideally, I'd say a long course of systemic therapy, like 6 months at the least, or even up to a year, to make sure that that the tumors are responsive, and to give a period of time to make sure that no additional metastases do develop. This answer is a very different answer than I would have given 5 or years ago, and it's really been made possible because the systemic therapies are getting a little bit better with FOLFIRINOX or gemcitabine and Abraxane, which once the systemic therapies do get better, this enables a bigger role, or a role for potential more aggressive surgical resections. I would say that these patients should be managed and treated at high volume centers that are studying this and are looking at this and looking at the real benefit of surgical resection for these patients with oligometastatic disease. Shouldn't be done necessarily as just a one-off case, at a hospital that does fewer of them. The things that we really look for, as I said, that these patients should be treated before surgery. The things that we really look for are that they are responsive to the treatment, and that's mainly measured or assessed by looking at the CA19-9 tumor marker. And in the few cases that I have done, for example, in patients with oligometastatic disease, patients got at least 9 months of treatment up front, what I would consider optimal treatment, and their CA19-9s normalized. if the patients don't make a CA19-9, which happens in about 10% or so, that we make sure that their FDG PET scans become negative, or the tumors are no longer metabolically active. So I would say in terms of should patients with metastatic disease undergo surgery, for the most part, no, but in very, very, very select cases, in patients who have received a lot of treatment up front, have declared themselves to have responsive tumors, it can be considered and should be considered within, high volume pancreatic cancer treatment programs, where these patients are being carefully studied, assessed, monitored, and frankly, published on in the literature, so we can continue to learn more about the benefit utility of surgery in these patients. There is all that being said, there is other subgroup of patients who have been shown, again, really retrospective surgical series literature to benefit from surgical resection with stage 4 disease. And those are patients who have undergone pancreatic surgery in the somewhat remote past, have a good disease-free interval, and then develop small volume pulmonary metastases. These patients, are treated with local therapies, whether it be ablation or potential surgical resection. And I think that the field does think that if there's small volume isolated pulmonary metastases, isolated, that a local therapy may potentially be helpful or beneficial to this patient subgroup. So many complexities. Another reason why it's really important for these folks to be managed at high volume centers that are accumulating experience with this, what I would consider very, very specialized disease and very specialized clinical context of the disease.